Hello, everyone. Thank you for joining us for today's episode of Let's Get Vaccinated on HoodMed Chats, Black on the Spectrum. I'm Dr. Nisi Hudson, Chair and Science Director of Hood Medicine Initiative.
I'm Jonathan White, co-founder and director of policy and engagement.
My name is Doug Slaughter. I'm the Director of Public Health.
Hood Medicine Initiative is a nonprofit collective of scientists, hackers, physicians, and other assorted geeks. They're focused on health equity and reducing the spread of misinformation.
Our HoodMed Chats podcasts connect health experts and activists to bring real talk and mad science to our communities.
Today, we're chatting with autism experts, Dr. Emily Hotez, and soon to be one of another of our guests, Dr. Khendra Peay, about health equity and disparities in diagnosis and care for Black and Brown kids on the spectrum.
Dr. Khendra Peay is boarded in both general psychiatry and child and adolescent psychiatry. She has a BA in pre-medicine and psychology from Wellesley College and completed her medical degree at Virginia Commonwealth University. Here goes Dr. Peay here. She completed her psychiatry residency at Indiana University. She was one of the first in the U.S. to receive separate fellowship training in autism and developmental disabilities through a state-funded grant. She co-founded and served as psychiatric director for an autism identification and management program at in Western Maryland, provides special needs training for local emergency room staff and consulting services to schools in her local Washington, D.C. area. Welcome back, Khendra. It is great to have you again, and I love you.
Thank you.
I know, right? It's been too long. How have you been?
I've been good, as good as can be. So yeah,
Yeah.
yeah. How about you all?
We've pretty good. We've dropped a link in the chat if you follow Kendra. We're super psyched to welcome back Dr. Emily Hotez, a dear friend and collaborator, and a fierce advocate for neurodiversity. Emily is a developmental researcher and assistant professor of medicine at UCLA. And throughout the pandemic, she's been focused on public health communications tailored for neurodiverse and disabled populations. She has a BA in psychology from George Washington University, a master's in developmental psychology, and a PhD from the City University of New York. Emily, thank you so much for joining us.
Thank you. Great to be here.
Gonna drop her links in the chat as well if you guys want to follow her.
Doug, you're on mute.
Oh no! I was like,
Thank you. 2 years, and
watch that mute button now. We're still in apocalypse. Watch that mute button.
So we're coming to the end of Autism Awareness and Acceptance Month, and gearing up for Children's Mental Health Week. So we wanted to focus on autism for our discussion here. So the CDC has put out some stats showing that Black and Brown children are still less likely to be diagnosed with autism spectrum disorder, and we want to unpack that some today. So Khendra, I'd like to start with you. Please tell us about your work and kind of give our audience an overview of what it entails and what is encompassed with respect to autism spectrum disorder.
So when we're thinking about an autism spectrum disorder, biggest piece to know is that we're talking about a neurodevelopmental diagnosis. And that's significant in the sense that we're talking about a bit different than things like just anxiety or just depression. You're talking things that we're really looking at milestones that we would expect to be met within typical development, with a range of typical development that are not being met in the timeline that we would expect. So a lot of times we're really relying as specialists on primary care, pediatricians, family practitioners to be able to first identify, okay, this child is not speaking at within the time that we'd expect, or we're starting to see challenges that we're not improving in terms of social connectedness. This goes into the diagnostic criteria when we're talking about an autism diagnosis, where you're really talking about a set of symptoms. Each one by themselves, anyone could really have. You're talking about, again, an early diagnosis. So we're talking about symptoms between the ages of 0 and 3 of really first presentation. Typically, most kids are diagnosed and seen in earlier years, but there are a lot of kids who are not diagnosed until later. And there are some adults who are diagnosed that may not have received a diagnosis in their earlier years. But you're talking about a core social impairment. You're talking about repetitive restricted interests, a non-adherence to routine, and you're talking about hyposensitivity. I can go into more detail about those a little later with Dr. Hotez also adding in. My role as a specialist is where I do diagnostic evaluations in terms of determining if this is something that we should be either concerned about as being the diagnosis or if it's a differential diagnosis, a diagnosis that we want to consider as a possibility in terms of some developmental concerns that we may be seeing. A lot of times kids who might come to me and present, it typically may be more because we're seeing behavioral concerns like tantrums or aggression, or difficulty with severe anxiety. And again, anxiety in kids really presents more behaviorally, where we're talking again, aggression, irritability, things like that, or just completely shutting down. That's typically when I'm doing evaluations. My part of evaluations also is determining if this is, depending on what stage of development we're in, if it is warranted that we should consider things like medication management to target symptoms of anxiety, irritability. ADHD is a common comorbidity with these diagnoses. So there's also, another role I have, I apologize, is also where if the child has not already received additional services, because when we're talking about neurodevelopmental diagnosis, you're talking that we really need to have a team. It's not going to be a one doctor just manage this. You're talking about a team that includes speech therapists, a language pathologist, occupational therapists, psychologists, psychiatrists, primary care doctor, looking at what additional services in school. But again, this is a piece of it being a neurodevelopmental diagnosis.
Dr. Hotez, building on that, can you tell us a bit about your work and talk about neurodiversity more broadly to help us understand what is meant by intellectual and developmental disabilities? And first, why do you think the term neurodiversity is an important addition to the lexicon? How should we view intellectual and developmental disabled? Sorry, the intellectually and developmentally disabled, given that prism of understanding?
Sure. Well, first, thank you so much for having me. It's an honor to be here with Dr. Khendra also. As Dr. Hudson mentioned, I am an assistant professor at the David Geffen School of Medicine at UCLA, and a developmental psychologist, researcher, and I think most importantly, a sibling of an autistic adult. So my research program is really based on a lot of my personal experiences in being a sister. And it focuses on promoting the health and well-being of autistic, but also other neurodivergent individuals across the lifespan. And to answer your question, Jonathan, by way of background, 1 in 6 children in the U.S. has an intellectual or developmental disability, or IDD. And these include a wide range of conditions, such as attention deficit disorder, autism, cerebral palsy, learning disabilities, seizures, developmental delays. All of these conditions could have or perhaps do not have intellectual impairment. So when I refer to neurodiversity, or when I refer to neurodivergent people, I'm generally referring to this group of people. So the term neurodiversity refers to the broad spectrum of differences that exist in the way in which we think and process the world. Having neurodivergence is just like having red hair. It's a facet of one's identity. The neurodiversity movement advocates for an emphasis on enhancing the quality of life and well-being for people with disabilities, rather than seeking to find a cure or make them more normal. So that said, neurodivergent people experience really pronounced health disparities, which is one of the reasons we're here today. We know they have increased rates of cardiovascular disease, diabetes, epilepsy, co-occurring psychiatric conditions, GI disorders, other chronic conditions, as well as lower overall health relative to the general population. And even children with neurodivergent children experience or are at risk for a host of cardiovascular, metabolic, and other disparities. And all of these are obviously compounded by barriers to engaging in health promoting lifestyle behaviors that many of them experience. And on top of all this, we saw that the COVID-19 pandemic really revealed and exacerbated health disparities experienced by this population all across the lifespan, with having an intellectual or developmental disability, such as one of the ones that I mentioned, emerging as one of the strongest predictors of contracting and dying from COVID-19. Neurodivergent people experienced more severe illness, greater risk of hospitalization, and almost twice the case fatality rates of the general population. And while the disparities that I'm mentioning that are experienced by neurodivergent populations obviously stem from a complex multitude of factors, my own work has had a particular emphasis on addressing their health disparities resulting from chronic stressors such as stigma, which I know we'll talk more about today. And I'll just say that while most people, when they hear the word stigma, they might think of overt discrimination or bullying. But stigma can really be more indirect and subtle. And this is really the root of so many of the health disparities that we're talking about today in terms of diagnosis and assessment and receiving critical supports and services. So I really believe that stigma is a potentially preventable contributor to health disparities for the neurodivergent population. And my work really focuses on individual, interpersonal, educational research and clinical approaches that we might want to take or test or develop in order to combat stigma. So I'll stop there, but happy to discuss any more of this as we move forward in the conversation.
Certainly, I think there's a lot here for us to dig into, but let's start at the beginning. So, Khendra, can you explain the sort of pathway a child or their family would take to be identified in the first place and to start the road to diagnosis, and what the components of an effective support system in terms of resources thereafter might look like?
Absolutely. Thanks for that question. So, biggest pieces that we want to really emphasize is access to care, because that's really going to be the biggest piece of being able to have things identified in the timeline that we would like to identify. So, the earlier the intervention, the more benefit, the more long-term positives that we'll get to see, where we really can see a lot of things. For some kids, even be just reduced so significantly that it's not even the same level of impairment. But even for the kids who have more challenges, the earlier the intervention, the better in terms of, we're talking long-term prognosis. Steps would be really, we're looking, I'd say honestly, as early as that first year of life. So in that first year, where especially when it's a first child or even a second or a third or a fourth child, it's something where we're really looking to see what is happening that we would expect to happen developmentally. Are we seeing things like, let's say, a social smile happen by like 9 months? Are we seeing things like back and forth in terms of just even looking for, when we talk about babies, that once they see you smile, then they engage back in a smile, or once they figure out that that's what makes you smile, are we seeing those things happen within that time? Language is a big piece. We do see a number of kids who have either delay in language or no language development in terms of verbal language. Let me be clear on that, verbal language. So we're expecting to see first words that aren't like mama, dada sounds happen by the age of 1. That you're starting to put together at least 1-2 word combinations by the age of 2. Are we seeing those things happen? Are we seeing either a regression where they started to and then no longer we saw it, or are we seeing that those things didn't happen? Are we seeing that kids aren't doing, by the age of 18 months, being able to point out things, like to draw your attention to it? Let's say that toy or something like that. That's what we call joint attention. But that is a social development behavior in terms of engaging your interest in your eyes into what they want you to be interested in. So if parents aren't seeing, let's say, just those few examples, amongst some other social behaviors or difficulty with language or lack of language within the first 1 to 2 years, needs to be brought up to the primary care doctor, either the pediatrician or the family doctor, and let them know that there are concerns. The minimum that should happen is at least to get a referral either to a speech and language pathologist, or to at least have sooner evaluations, sooner appointments to make sure, are we seeing any progression, so that it doesn't go in a longer period of time. A lot of times the school may be also, if the child's in daycare, that would also be something where to check with daycare to see, okay, have you all seen any improvement in this area? Or if daycare brings up concerns, that would also be something to bring to primary care doctor. That would be the first step.
And like hearing that, Khendra, can you talk a little bit about how this sort of paradigm of like going through the process of diagnosis changes when we're discussing Black children? Like if the typical timeline involves like months of assessment and evaluation, um, I think they reported the average delay for Black children more like 3 years. And that's even if they get what they need and aren't just tossed aside. So why are these delays like disproportionately affecting our kids?
It's hard because there are a number of factors. One piece is access to care in terms of kids not being seen, being able to have access to be seen in the timeline that they need to. And even if it means having to use vaccination shot visits as the time to talk about those things. The second piece is also having enough time and an appointment for all the things that need to be brought up, but recognize them as concerns to be brought up. So this is a piece that also comes to make sure that you feel comfortable talking to your primary care doctor. If you don't feel comfortable talking to them, or don't feel like this is where you're able to express every concern, regardless of how you think they may respond, then it needs to be finding a primary care doctor that you can feel that rapport with and can feel that support with, because we don't want these things to be missed because of that piece. The hard piece also is that because kids typically will manifest their behaviors will be a manifestation typically of concerns that are happening in the brain. So we see a lot of kids, let's say if they're having a lot of tantrums, that is something that I say absolutely bring up to primary care. It's not something where we want to put it into a box of that's just how he does when he gets angry, or he's just upset because that didn't happen. If it is happening on a frequent basis where there are frequent redirections needed, or frequent frustration, or really difficulty with tolerating stress from the child, let's say by the age of 3, that needs to be brought up to primary care. It cannot be something where, even if we've seen other family members who've had similar behaviors, it is still something that needs to be brought up. Even if you tell the primary care doctor, well, his cousin does the same thing, that actually would be significant from a medical standpoint, because sometimes we have family members who don't receive formal diagnoses, but actually may have diagnostic concerns that are going on also.
That's very interesting because I think, in Dr. Hudson, you'd probably agree with this. Identifying and securing primary care physicians that we trust and can really have a conversation with has been one of the central themes of almost all of our discussions about medical issues, particularly health disparities. And I think in our community, particularly, we have a hard time, finding and locating doctors that we can really bear all with and trust on a level where we can have these very blunt conversations. Um, Dr. Hotez, what is the cost of these delays? What ongoing care are these kids missing out on? And how much harder does this lapse make things for them as they grow and mature?
Yeah, absolutely. We know from the research that Black children are less likely to be diagnosed with autism than white children, despite the fact that Black and white parents report their first concerns when their children are of similar ages. We also know that Black autistic children are often misdiagnosed with other psychiatric disorders. Among those diagnosed with autism, clinical presentation is often different than that of white children, suggesting that Black children with different symptoms might be completely missed altogether. And by symptoms, I just mean different presentation of autism. So this is a problem because we have very strong evidence that early experiences play a pivotal role in lifelong development. Developmental psychologists typically refer to the period between ages 0 to 3 as a sensitive period, So that's a period in development in which environmental influences may be particularly critical for building brain architecture and promoting healthy lifelong development. And children are eligible to receive early intervention supports and services within this time window. After age 3, children are no longer eligible to receive early intervention services. Then they have to receive their services through the school system. So what this means if Black children are being diagnosed 3 years later is that they miss out on critical services and supports that could, for example, empower parents to develop skills and other capacities that can help their children thrive. Dr. Khendra mentioned that serve and return interaction between parents and children that can be so vital for development. These services often help parents to optimize their child's development. So this, of course, means that children, Black children in particular, have to wait until they're in the school system to receive the support that they need and are already playing catch up. But of course, this is not to say that, we know that health promoting early environments are not enough to inoculate, so to speak, against other adversity experienced across the lifespan, but they're still critical nonetheless. So if children are not receiving these high quality research-backed supports and services that they may need based on their individual challenges, they're at a disadvantage in terms of social and emotional development and executive functioning, just to name a few. And we see disparities in Black autistic individuals across the lifespan. A study published last year found that Black autistic young adults have significantly higher depressive symptoms, for example, than white autistic participants in the study. And, of course, we have no way of knowing if this is tied to receipt of early childhood programs and supports, but we do know that health disparities really persist across the life course. And if there are steps that we can take at critical developmental transitions, such as that sensitive period between 0 and 3, that will be a really important step towards addressing inequities.
So, just to follow up to that, I think anybody here who's a parent understands that raising children, generally speaking, is a very difficult process, particularly early on. Um, could the lack of understanding of what your child may be experiencing as a parent make that an even more difficult, journey as a young parent? Not understanding that your child may need resources that you don't necessarily have, thinking your child may not be particularly paying attention or following directions the way an quote unquote normal child may. Could that add stress and trauma to the relationship between parent and child at that early of an age?
I agree that it is certainly critical that parents are equipped with all of the knowledge and resources and advocacy abilities as much as possible. So I believe it's really critical that we empower parents with this knowledge, and parents are already experts on their children. So having parents be able to advocate for themselves and their children within the system is really important. But of course, identifying those early signs of autism, as Dr. Peay mentioned, it can be really challenging. Parents are often able to tell if their child has delays in walking or talking, but not always when it comes to those more subtle nonverbal social communication milestones like eye contact, pointing, or other gestures. So my recommendation would be that parents speak up to make sure their physician is screening for autism and responding appropriately. But of course, that also implies that the parent has an established trusting relationship with their provider, which, as you mentioned, can be a big hurdle. So it is the physician's responsibility during a well-child visit to screen for autism and refer the child to a developmental psychologist for a comprehensive evaluation if they do suspect that the child might be autistic. Physicians use several validated tools in order to pick up on those really difficult to sometimes see, those difficult nonverbal communication behaviors and skills. But even though the American Academy of Pediatrics recommends that every child is screened for autism at well child visits, this historically has not been done consistently, and many children have been missed. We're also learning that autism doesn't always present itself the same way across different groups. For example, autistic individuals assigned female at birth, they may present differently. And so some of my work at UCLA has focused on identifying strategies to better train medical students and future physicians about neurodiversity and about autism. And I know there are many ongoing initiatives to do this across campus worldwide. So I'm hopeful that provider efforts will ameliorate the burden on parents. Parents need to kind of take matters into their own hands. We saw in an earlier study this year, a qualitative study of Black autistic children, parents need more social support from providers, and they also need more inclusive spaces where they can engage with other parents who might be able to relate to the stressors that they're encountering. So my take would be that, yes, we want to empower parents, but at the same time, it's really critical that we address these systemic barriers to diagnosis, assessment, and services.
Thank you.
Dr. Peay, you had a follow-up as well?
So a couple of, and I'm in agreement with everything that Dr. Hotez said. A few things also in terms of, this is also a really big reason why we want to make sure that there's a good relationship with the primary care doctor, because it's not only about providing information to them, it's also about hearing what they say too. This is their job to, in terms of from a training standpoint, to know what developmental milestones should be met and not met, and when it should be a concern. Sometimes, and this speaks also what Dr. Hotez said, sometimes we can see a difference in symptoms presenting, but sometimes we can actually see the same symptoms presented for a child who is Black or brown and still not receiving a diagnosis. That piece goes into the systemic concerns in terms of sometimes things not only being misdiagnosed, but also underdiagnosed because of either racist perception of what we think the child should be doing, or also, especially let's say if we see aggression, which is a lot of times where we'll see boys who have an autism diagnosis. Typically, that's where they are, we're talking 4 times more likely to have a diagnosis, but also that's honestly one of the reasons why they get diagnosed sooner too, because they typically present with more safety concern behaviors compared to another child or a child assigned female at birth might be presenting with early on.
I have a little bit of a follow up there, right? So you said that some of these things get misdiagnosed in our children of color. So how do we address stigma with respect to this, so that these identifiers, these early identifiers of autism spectrum disorder can be treated as such and not missed? What are the tweaks that we need to you know make in our families and our communities? How do we make this more norm? How do we normalize this and the experience of it, so that we don't miss these things and they don't get misdiagnosed?
I could go first. I mean, big first thing is recognizing that behavior is something to be addressed and brought up, period. It doesn't matter what the behavior is, bring it up to primary care. And that's because behavior always tells us that something is going on. It may not mean there's autism. It may not mean there's anxiety. It may just mean that the child is not having enough caloric intake, or it may mean the child is not getting good sleep at night. Either way, behavior tells us that something is going on. So even if we see other kids with similar behavior, if it is something that is requiring frequent redirection or more supervision than what you would expect to be doing, it is something that should be brought up as a concern.
Emily, did you have, yeah.
Yeah, I would agree with that. It is really important that parents do feel able to bring any of their observations up to their physician about about their child. But at the same time, because I'm so steeped in this work of physician education and medical student education, I can't help but bring up that, we oftentimes think physicians know everything and are experts in everything, but physicians, by and large, as well established in the research, do not feel very comfortable helping patients who are neurodivergent or their families. They don't have specific training in many neurodivergent conditions, and they certainly do not always provide neurodiversity-oriented care, meaning care that is flexible and adaptable to the individual needs of patients across the neurodiversity spectrum. So I would say that while concerted efforts to promote awareness and kind of reach families are essential, and I think that's where a lot of the work of Hood Medicine could come in, is empowering parents with knowledge and information and reaching those parents who might be marginalized. There does need to be a concerted physician effort to teach them about autism and how it could present differently in heterogeneous populations. Within the autism world, it's said that if you know one autistic individual, you know one autistic individual, because it looks really different based on the individual. So it is, I am certainly not discounting the challenges that physicians have in responding to issues related to neurodiversity, but we certainly need to ramp up their training as well.
And I just want to add exactly what Dr. Hotez said. If your child is not improving, let's say you've gone to primary care, you've brought up your concerns that, hey, I keep seeing this behavioral concern, or they seem like they're frustrated all the time, or he or she is still not talking. And if there is no improvement, or if you feel like it's still not sitting right, absolutely go see a specialist yourself. You can go ahead and make that. It doesn't require, and a referral, it can happen, but it's something where you could actually go ahead and see a specialist yourself and schedule that. And that is our training. That is something where we are to know all those things. So that would be the other route that I would say also, especially when you know that, okay, they may not, because exactly like Dr. Hotez said, it is something that it does require a different eye when we're talking about looking at it. And that's a piece of the additional training.
Dr. Peay, something you said earlier was really worrying to me because, it sounds like schools play a really big and kind of shepherd kids through this diagnostic process. And I just feel like for me, that's one of the biggest red flags of this whole conversation, because can you just talk to us about like the role that racial discrimination and like over policing of our children in schools, has in this landscape? Like, are we seeing Black school children just being met with like disciplinary measures instead of getting those referrals that they really need?
And that's a piece that I agree with you. That's a huge concern, because you're talking about, that's really where the majority of the day, that's the child's majority of the day is spent in that setting. So there are a lot of things that we rely on in terms of education being provided equally, but also that we're also getting eyes, the same sort of eyes for another child, recognizing there's a concern or that something may not be happening. And I, not to say that I expect them to be, developmental specialists, but to know, okay, this child is really struggling, or even that they always seem frustrated. That would be the time definitely to then seek having a school meeting, especially if you're continually getting calls, or if you are continually getting reports from your child about being frustrated or even hating school. Any of those things. Those are things that are indicators, like, let's first set up a school meeting, because that actually can start the pathway to getting a medical evaluation. Referrals can come from schools too, and sometimes they come from schools just by there being an IEP that all of a sudden went into play.
And do you feel like, I know that you see a lot of children in your practice, do you get the sense that there's sort of like a labeling that happens with them, whether it's like as a problem child on the disciplinary side or otherwise?
Right. So the fortunate thing is that by the time the kids get to me, I'm able to be a different type of advocate for them if we even start to see the beginnings of those things, where I will directly speak with the school to make sure that if
Okay.
I think there's a misunderstanding about who, but that's a piece of where your provider, even if it's not a physician, the psychologist, the social worker, whomever is working with that child, to really for that to be an advocate, to also let the school know that what they're seeing is something, because that is a high risk, and there are a number of kids who do get mislabeled for having challenges, and that can include even when we're talking about intellectual disabilities. Having autism can be highly associated with having an intellectual disability, but not necessarily. You can have kids who have an autism diagnosis who don't have that diagnosis. And also when we have kids who may just have an intellectual disability, which again, like Dr. Hotez said, is also a neurodevelopmental diagnosis, you may see that instead of them being able to verbally express, which makes sense at young ages and at certain ages, we don't expect that ability to be able to say, hey, I'm having a hard time reading. Some kids are able to do that, but some kids will just act out their frustration or start to do disruptive behavior in the classroom. And then it gets misinterpreted as, oh, this is a child who's having challenges, where the reality may be that this is a child who can't read or who does not understand what's being said. Or if we do have, let's say, a child who has an autism diagnosis and all of a sudden things switch up. And when we're talking about having an autism diagnosis, you're talking about not only having a risk of restricted interest, hyper-focused interest, but also severe difficulty with routine changes. So it could be something as simple as a substitute teacher coming in that now all of a sudden we see behaviors, and the school may interpret it as, oh, well, they're just acting up because the substitute's there and everybody thinks that they can act up on that day. But that's a projection of what their thought is. If we're seeing a lot of challenges with difficulty when there's anything that changes in the schedule, that's an indication that, okay, we need to get this looked into more.
Along those same lines, when I was growing up, we heard a lot about kids who were put on medications to calm them down in schools and whatnot. And so, as I've become a parent, people in my generation are typically a little more hesitant to allow their children to be diagnosed. They don't want their kids put on Prozac or any meds. They don't want their kids to be labeled anything. Often we kind of say, oh, they're just hyperactive. They're just boys being boys. Can you talk to us about how you can connect with a parent who's sort of in that realm where they're a little hesitant to allow their child to be diagnosed with something that may be a legitimate neurodivergent, issue?
Sure. So when we are thinking about medication as an intervention, the biggest piece that I like to make clear is that we're talking about that being one type of treatment intervention. It does not take away from other treatment interventions being necessary, and it doesn't necessarily mean that we're at that point of that type of intervention. No different than other health issues. So, depending on the severity of what the concerns are, that's what decides, okay, is this something we need to consider sooner versus later? Similar to, say, diabetes. If it's something where it is really to the point that that child is not functioning, not getting into, type 1 and type 2 just yet, but in a sense where that child is really not functioning versus seeming as though, okay, this may be something that could first be managed with diet and physical activity, versus that's tried and the child is still not improving. That's when we look at, okay, what do we need to do from this type of biological standpoint to intervene? Because at that point, we're speaking to, this is beyond just something that they are able to do. And that's a hard piece when it comes to, I'd say, diagnoses and disorders of the brain, because you are talking about behavioral manifestations. And so a lot of times people assume that it's something they can control. Yes, there are some behaviors that we can control, but there are some things that we can't. And if someone continues to get in trouble or frustrated about the same things, regardless of what the interventions are, then that would speak to that there's something that may be biological going on that we need to assess. Medication, when I see families, is never, I make it clear, that's never our first go-to. We first want to see, what have we done already? And is this something where we could wait? Do we have the ability to wait? Because if there's a safety concern and it's already identified that this is something that requires that type of biological intervention, similar to any other health issues, then we do need to talk about this being something to help them to be more available for the other therapies. Because if our baseline is not at the place that we needed to be at to engage in those things, it's really not fair to the child to expect them to be able to do all the behavioral work we need them to do if they're not at that biological baseline that they can engage in that. And it's important to know too that medication doesn't mean that this is a life of medication. It means we're looking at a moment in time. We're looking at this moment in time, what do we need to address to help them to be their best self and to help them to be their most successful? Because when we have kids who, again, get late diagnoses or misdiagnoses, you're talking about years that can go on that now this child starts to think that this is just a part of their personality, who they are. Family members start to get used to that behavior, and then things can continue to get worse over time versus earlier intervention, really allowing us an opportunity to really change the trajectory for that child to really have a more successful path for themselves, whatever their path is going to be. But it's a long conversation. And sometimes it's a few conversations that need to be had, because it is, when we're talking medication for any condition, it's something where we really want to make sure that we're getting, just all the information. But this is also the reason why it's important to see people who are trained in pediatric work. My training is different than an adult psychiatrist. I do my adult training and I'm board certified in adult, but my fellowship training in child and adolescent and then my fellowship training in autism puts me in a different space in terms of how I can think about not only the developmental piece, but also what the medications are going to do at different ages and when there's a concern, and really thinking about safety. But that's a piece of making sure that you see somebody who really is actually a specialist in pediatric world.
Just like thinking about the delays and how that kind of like projecting forward and also maybe looking back. I don't know, I guess, like, what would you say about people from older generations, like hashtag asking for a friend, where like autism was definitely not on the radar in Black communities. We weren't getting screened and diagnosed. Like, what about people who, might be struggling as like young adults and older, with different issues who've never been diagnosed or don't realize that they may be neurodivergent? Like, are there ways to continue to support people after they've missed that developmental window, Emily, I'll start with you.
Sure. Yes. I think it's important to continue to think about neurodiversity across the life course. And so many of the health disparities that we see, for example, are due to differences in fit between an individual's specific needs and the environmental constraints. So creating environments that are neurodiversity oriented can help to continue to support neurodivergent people across the life course. So maybe that means rethinking the traditional educational environment in schools that might not be conducive to diverse learners. Beyond that, in college, that's where we've seen the majority of the work in the neurodiversity movement take place, and I'm hopeful that it will expand out from there. But then also in healthcare settings, in job settings, the neurodiversity movement is beginning to proliferate across all of these sectors in order to support people who either have diagnoses and are older or don't yet have a diagnosis and maybe will one day receive a diagnosis. There's kind of a growing field that's meant to support neurodivergent older adults, but there's certainly more work to be done. And we are beginning to see some emerging research on kind of intergenerational approaches to early childhood programs. So how can early childhood programs also support parents and grandparents who are often really pivotal in the child's life? These programs are typically meant to be attuned to cultural differences in which a grandparent might be raising a child, for example, and are meant to also promote the optimal health and thriving of the older adult in addition to the child.
And can I just add also, I agree with everything Dr. Hotez said. The other piece too is us needing to reframe what is okay. Because a lot of times when we think about generational, we're like, well, he ended up okay, or I ended up okay. But we also don't want okay to just be I'm surviving. Like I'm surviving does not need to be what okay is. We're looking, especially we all want our kids to do even more and beyond the things we're doing. So we need to think about okay, even if this was something that I survived through or that I didn't get those resources, that it doesn't mean that we need to have that same baseline for the child. It is looking to see what is the most and just the most resource that we can get and just what is the best in terms of resources that we can get.
Amen to that.
We had a question from one of our viewers who has um, uh, a well, I'll just share. So she wanted to know how you have a discussion with a spouse when you have concerns or suspicions with respect to stigma and signs of autism. It's an open question.
I'll let Dr. Khendra weigh in just because I imagine you encounter this pretty typically in your practice.
Absolutely. I'll give kind of two answers because I want to be sure is regarding when you have concerns or suspicions when they're assigned for the child or your spouse, because there can actually be both in terms of where sometimes adults don't get diagnosed in earlier childhood and they present with in adulthood challenges with social interactions, really struggling with routine changes, transition changes, hyper focused interests, but functioning at a level where it's something that may not necessarily impact let's say function of income or things like that. When it's the child, it is a harder one. This is a piece where you have to have the entire team. So the hope is that there's a pediatrician or family practitioner on board that you trust, but that also that your spouse identifies as being a source of knowledge. Even if it is not a someone who is warm and fuzzy, just identifying them as a good and accurate source of knowledge. Because it is going to be something where that should come from them in terms of, hey, we're also seeing these same concerns. Sometimes it can be something too where you can provide a comparison. And this one's a hard, I don't really like when kids get compared to other kids, but in the same breath, we are talking, that it's something that we are seeing developmental differences. So that is technically a comparison. We just don't want to become a comparison of someone being better than someone or anything like that. We're just talking about developmental differences. John down the street, he's already been making, multiple sentences and he's having back and forth conversations and he's 5, but we don't see that with our child. And it's hard because sometimes it can get minimized as being timid or being shy when there's a language issue, but we shouldn't be seeing something if we're not seeing development of interact, in terms of that back and forth interaction and ability to really form sentences. That's not being timid. That's something where we're talking that there's a language concern that needs to be at least evaluated.
Yeah, and I think we have a second question from another viewer that's similar to this. So it seems that there is a question or concern among even parents of kids on the spectrum about how to engage with other parents. So this question is from Zakia. She wants to know if you have any suggestions on how to get certain types of parents out of the mindset that being diagnosed is seen as labeling their child in the way that we discussed was negative before. And how do we get them to see that it opens more doors for resources to aid and help versus harm? And for context, she's the mother of a 10-year-old with autism spectrum disorder, and also an advocate for autism diagnosis and care.
My hope would be that the physician is able to have those conversations with the family where they're able to provide education about neurodiversity and about what exactly a diagnosis will allow families to receive in terms of services and supports. And if not the physician, then the specialist who they are seeing to actually get the diagnosis. But it is certainly a challenge. Even during my doctoral program, autism was presented to me as you're looking for the red flags of autism, and it was really presented to me as something that when it's being diagnosed, there are concerns about all the symptoms. And the red flags and kind of a very negative connotation around the diagnosis. And I think increasingly physicians are reframing the conversation a little bit, but I agree that it is a challenge.
So Emily, I know that you have to jump off in a bit, so I thought we would just, before you have to leave, give you a minute to talk about the work you're doing right now with the neurodiversity health chats and the workshops, et cetera. I know it's been going really great. So talk to us about your grants and the projects you're working on and why it's so important to ensure that there's effective COVID communications and outreach specifically to neurodiverse communities.
Yes, thank you. I am so excited to tell you about this work. So this is work that I'm doing with a student organization called Neurodiversity Health Chats and also Hood Medicine. And it's funded by a joint cooperative agreement between AUCD and the CDC. Back in May 2021, which now feels like another lifetime ago, we were awarded a Dissemination Innovation Mini Grant from this program in order to understand and address vaccine hesitancy and increase vaccine uptake in neurodivergent communities. And my students here at UCLA Health did a fantastic job on this project. They conducted interviews with many different stakeholders, physicians, nurses, psychologists, social workers, scientists, and neurodivergent individuals themselves. They also had an interview with Dr. Khendra, which you can see on the Neurodiversity Health Chats page. And then they formed a group called Neurodiversity Health Chats, where all of these interviews are now housed. And from this work, we learned that those who seek to serve neurodivergent communities cannot continue to work in silos. I'll just throw in a study that was published last year found that across a 77-year period, only 3 studies foregrounded Black autistic women and girls, and none adequately addressed intersectionality. So to me, this indicates that those who are serving marginalized groups are not working together. And it's clear that we do all need to work together to become effective public health messengers in light of the health disparities that resulted from COVID. And so that's where Hood Medicine came in. Hood Medicine trained our students in their model, developing and disseminating culturally tailored social media content like infographics in order to reach a heterogeneous group of neurodivergent individuals through social media. And then recently we were fortunate to receive another mini grant from the same cooperative agreement to not only have Hood Medicine train my students at UCLA, but to train public health professionals across the country to become effective public health messengers. So Dr. Nisi Hudson runs these workshops. They are focused on helping direct support professionals, nonprofits, students, trainees, and others to reach neurodivergent populations, particularly neurodivergent people who might have multiple intersectional marginalized identities, such as BIPOC autistic populations. So we kicked off our first of our 4 workshops in our Inclusive Public Health Workshop Series last month, and our next one is on May 2nd at 3 p.m. Eastern. And I'm sure we can link the registration in the chat or in the notes from this chat, but all are welcome for our workshop.
Yep, I'll drop the links in the chat for sure. But thank you so much for spending some time with us. We're going to continue on with Dr. Peay, but
of course,
good to see you again.
Thank you. Take care.
I always love seeing you, Dr. Hotez. Take care.
Bye-bye.
Take care.
righty.
So
So, Dr. Pay, we have a
I
few
was
more questions for you, so we'll keep going.
Do you want to dive into mainstream autism communities, Dr. Hudson?
Yeah. So basically, like, you know, I think there's been like a really cool movement lately among like millennials and younger, kids, social media, kind of defining their own communities like autism while black and black neurodiversity, and just kind of demanding a carving out of space for those communities to feel seen and validated, I guess. And so I guess, you know, from a social perspective, um, do you feel like there's been some like gatekeeping around neurodiversity, which communities kind of, get resources and publicity and like, kind of engagement from the wider world? Are there ways that we can kind of change that?
So, from the gatekeeping standpoint, I definitely say that it depends on what diagnoses are the most seen at different times. So when let's say if schizophrenia, if there was something massive that happened from a news standpoint that involved that diagnosis, then there tends to be more attention around those things. Um, Autism is something the spectrum is something that does have a lot of resources available, and it does have a lot of interventions available. But that piece, it does really speak to being identified and referred to. But it is something that does have a lot of resources available.
Uh, Dr. Daniel Geschwin from the UCLA Center for Autism Research and Treatment recently said that it's not the parents who are delaying diagnosis; it's the system. And we've touched a little bit about the systemic factors that are adding to these barriers to diagnoses. But what he noted was that a study saw Black parents seeking help for their children, but having to uh, go through multiple providers before they're taken seriously. Uh, what would you advise those parents that have had to be that persistent? Would you suggest they seek out Black providers if they can, just to persevere through the ping ponging from doctor to doctor until they get what they need? What would you say to these parents?
It would be with Black physicians. There we're about 1% of the physicians in the country. So that is something that we are looking to improve, and we're continuing to try to work on things like retention and recruitment. So it would definitely be something that would be um, ideal in terms of at least someone who, even if they don't have a Black face, for at least for them to be someone who understands things from a cultural standpoint, from a racial standpoint, someone at least is sympathetic to the impact of that in every health aspect. So it may be more of that piece. The other piece is definitely feel free to go straight to a specialist also, because even if I have a family that comes to me who may not have actually been referred through their primary care, I also have medical training, so I'm going to be able to identify, okay, you should actually go back to them, or I'll be able to speak to their primary care doctor. There are things that we can do as a specialist, no matter what we're looking at from, whether it be rheumatoid arthritis, whether it be, a kidney issue. We will correspond back with primary care to make sure that that's something that we're getting full, well-rounded interventions and awareness of what's going on. So those may be the times to go ahead and seek a specialist assistance on your own too, especially if it feels like it's a challenge by going through the referral process.
Very good points. Uh, what role do you think the community care plays in building support systems for children with autism and their families?
So I'm sorry, say that one more time. Sorry.
What role could community care play in building a support system for children with autism and their families? We talked a lot, in Hood Medicine about building these community care networks around families to as a way of addressing these social and medical disparities that we see. So, how could a community care support system play a better role?
There are so many ways like that. So, because what we be talking about basically is you're involving the village, which is how it actually should be for any child, period. That this should be a village
Mm.
event. Even if we don't understand or agree with an actual formal diagnosis given, we're as a community, as a village, recognizing that there are challenges. There are health challenges that are happening. There are challenges happening that are interfering with that child's ability to succeed in school, at home, or with peer relationships. um, this is going to be the piece of also having conversations, but having trusted people that you're having conversations with, who you feel like would really understand that this is something that's a concern and it's something that's been going on for a while. And sometimes that may mean having to go outside of family unit and really looking into the community to see what resources are available in terms of education as the first part, because there has to be first that knowledge of what we're actually looking at to be able to then say, and again, not having to go into a full diagnosis at that stage yet, but at least the knowledge of, okay, this is something that I should not be seeing, that my child should be doing this, that my child should have these things available to them, and community resources being available to really help to identify what we need to get in place for that child in our community.
One quick question before we begin to wrap up. So I was talking to somebody who has a child with autism years ago, and I'm ignorant to the spectrum, I'm ignorant to neurodiversity, as I think probably most of us in our communities are. Um, the language that we need to have, the attitude that we need to have to be respectful of these folks. Do you say it's an autistic child or do you say it's a child with autism? How do you speak and what's the language we should use so that we can, make sure we are compassionate and caring about the folks who are dealing with these things?
Um, Both are commonly used. I say a child who has autism because I would say the same thing when it comes to an anxiety disorder, when it comes to depression, because I really want to identify that child as being the child first, and this is something that they have. Even when we think about anxiety, I like to think of it as this is a child with anxiety, as opposed to it being something that starts to get integrated into personality, as opposed to recognizing it as something that impacts who they are as a person and
Mm,
impacts who they are as an individual. But both are commonly used. But that's
thank,
when I'm speaking to families, I do say with autism or with those diagnoses, because I do want to be sure to to separate that piece from their individual. And it absolutely is a part of identity, but a part of
mhm,
identity is different than identity in total.
Mm.
thank you.
I think that's important because I feel like, you know, we also have a lot of attitudes about, you know, neurodiversity and mental health that are probably toxic. And the things that we say, even when we're just like, if I think about a family gathering and like the comments that adults make about kids doing certain things, it's like we really need to like become more conscious of, the way that we categorize and describe our children because they're listening. You know what I mean?
Mhm.
Yeah, I mean, when we grew up, Dr. Hudson, we used to call people who were likely on the spectrum, we used to call them slow. Or we talked about the
Yeah.
kids on the short yellow bus, and it was very
Yeah.
derogatory, negative ways in which we were talking about these things. And so that's one of the reasons why I love the term neurodivergence, because it makes it so that that kid is no different than anybody else. They just see the world and think in a different way than other people do. They see and they have a different level of intelligence, a different type of intelligence. And if we treat them as normal children that just look at the world a little differently, then I think that keeps them whole and human in a way that I don't think we did when we were growing up.
And
Mhm.
it's important to remember that every single person has challenges,
Hmm.
period. Everybody has challenges. So when we're talking about an autism diagnosis, when we're talking about anxiety, when we're talking about ADHD, that just means that is what their challenge is.
Yeah.
But everybody has a challenge. And that's a piece that really, I think, just as a community for us to really empathize, because we know it from just from a logical place of, okay, that everybody has something they have to deal with, But that being said, this is something that that child has challenges with.
Yeah.
And it just happens to have that name because that is their set of challenges.
Mhm.
Same thing when it comes to things like reading or learning differences. That's where their challenges are.
And back to a point that I think Dr. Hudson made earlier, even, and I think you were responding to, even if that was a challenge I had growing up that I got through, it doesn't mean that I need to force my child or someone else's child to suffer through in the same way I did, when there are resources out here available for them to, be able to do better than maybe I possibly did.
That's exactly, and that speaks to going into even bigger pieces like normalization of trauma. When
Yeah.
we think
Yeah.
about
Ooh, we don't have time, Dr. Peay. We about to wrap up. What are you doing? We're trying to wrap up. She
That's a
opened a
whole
whole
other
nother can
sermon.
of worms.
Oh
Right.
Lord. Woo. Mm-mm.
Man, and that multi-generational racial trauma is
Yeah.
hitting on all cylinders, boy.
exactly, and and all I'll say on that is that because again, just because it is something that we went through, that we had family members go through, doesn't mean that it needs to be responded to in the same way. Because
Yeah.
surviving is not the equivalent of okay. Me managing to, but still having recurrent nightmares, places I can't go, that doesn't have to be what the child's life has to be later. But a lot of that also means having to have folks that you trust from a community standpoint and
Yeah.
also from a health standpoint, health team standpoint, to let you know there are things available that doesn't have to be the trajectory at this stage in life.
Yeah.
Even the resources we have available now are different than the resources that were available 20 years ago, and definitely different than the resources available 50 years ago. I mean, when thinking back 50, these weren't even diagnoses. Again, people still had these diagnoses of autism, they just weren't given the diagnoses, and that was across the board. But it just being something where we had, we just have different classroom setups, or they would go ahead and do interventions that basically would manage that. But it being something that's, yeah.
Hmm. Well, we're like really excited that you had a couple more minutes to hang out with us today and answer some additional questions.
Thank you so much. This is wonderful. As always, I always appreciate everything. You all are amazing. Everything. This is fantastic. Because
So,
there are a lot of people that just don't. First, they don't really understand autism, and I definitely, I'd love to like talk more about it. Like I try to cut, but then I'd love to like as much more that you want me to talk about it. I can do it at any point in time because just to
Good.
be.
I'm going to hold you to
Yeah.
that.
It does first come to that, folks really first understanding what they're seeing and then being able to move, accordingly after that.
but before we go, we'd love to hear what you're working on right now, Khendra. Besides your work with Hood Medicine, what strategies have you used during the pandemic to mitigate some of these barriers for young patients in your work and your advocacy?
Well, because of the shortage of child and adolescent psychiatrists, I know I was saying before, it's like only 1% of physicians that are Black, but we have even smaller of Black child and adolescent psychiatrists. Most of my
Mm.
focus pandemic has been just making sure I take care of the families that I'm seeing and also taking care of other families from a direct care standpoint. I do consult work with schools and provide educational talks so that people understand things from a diagnostic standpoint. And also, especially, there's been highlighted more in terms of adolescent mental health crisis, even though there was a mental health crisis prior to pandemic. That's really been highlighted during pandemic. So also making sure that I can be of whatever availability I need to be locally to understand that more and understand what supports need to be in place. And then especially when we're talking about kids who have either an autism diagnosis or neurodivergent diagnosis, that we're talking then an added layer to things that would already be a challenge for an adolescent. So they are still an adolescent who is going through adolescent changes and adolescent challenges, and we have an added layer in terms of their lens of managing it because of that neurodevelopmental diagnosis.
I guess, yeah.
One last thing. So we really appreciate you taking the time to come and chat with us. We're Autism Month is Autism Awareness Month is important, and I think these conversations are important. Um, many of us have people in the spectrum in our families and have different experiences. Some good and some bad, and seeing uh, their journey to a diagnosis or lack thereof, in many cases. So I think these kind of conversations are important, and we appreciate you breaking it down for us. So are there any last thoughts that you would like to leave our audience with before we wrap up?
No, just that Hood Med Chat is amazing, and get providing and that's my final thought. And providing these opportunities to really be able to, provide this education and these resources and just the information that's needed for our communities is priceless. It really is priceless. So my final thoughts are thank you. That's my final thought.
Thank
Thank
you.
you. Um, Again, I want to thank Dr. Hotez, who had to leave us a short while ago, and you, Dr. Pay. Dr. Pay is my big sister. I love her to death. I'm super duper proud of her. I want to thank you for joining us and helping us to, wade through this, area of, medicine, and understanding that a lot of us just haven't had an opportunity to have conversations, very frank conversations about. So thank you for joining us today. Thank everybody for tuning in with us on this episode of Let's Get Vaccinated on Hood Med Chats. At Hood Medicine, we bring you real talk and mad science so you can make the right decisions to keep your loved ones safe, your family safe, your community safe, and yourself safe. Please follow us on Facebook, Instagram, and Twitter to support our effort, donate to our cause, and find out about our next events. Hoodmedicine.org is our website. You can find us on social media at hood_medicine on IG, Twitter, and Linktree, and on TikTok. We're Hood Medicine Initiative, one word, on Facebook. And you can support us through our bonfire merch shop at bonfire.com/store/gorilla gear. Thank you again. Stay safe, get vaccinated, get your booster shot. If you're over 50, get your second booster shot. And please love your folks, love your community, and love yourself. Thank you very much, guys. Take care.
Thank you.
Thank you.